to be here. I'm going to talk less about how the periods feel and the symptoms and the psychological component of them, and more about how we measure them, how we assess them, and how these different measurement techniques are going to inform or change our interpretation of what's actually going on. So a quick review of what actually is supposed to happen in a menstrual cycle. You see these curves here of the 4 hormones that we think about the most. And I want to call your attention first to this rise in luteinizing hormone that you should see prior to ovulation. And that's the one I think over-the-counter kits, the ones we see most often talked about are LH surges. But what we want to see to actually confirm whether or not ovulation did happen is this sustained rise in progesterone. And this is what you see in the textbook. These are nice, beautiful curves. When you get out in the field, when you do this in real life, it looks more like this. And it's challenging. It's challenging to get it right and to say, yes, this person's normal, this person's not. And I think what makes it more challenging is when we track cycles anecdotally, or when people self-report or think that they have normal bleeding patterns, it doesn't necessarily mean they have normal physiology. We were able to demonstrate that, and we weren't the first, but we were able to demonstrate that in an Army study where we followed women during 10 weeks of basic combat training. And every week that we asked them about their cycles, and 42% said that during that 10 weeks they had regular periods. 58% said they didn't, and that aligns pretty well with previous literature. But when we looked at their daily hormones through urine profiles, we found that 75% had no evidence of luteal activity, which means no evidence of ovulation. 12.5% did have evidence of luteal activity, and you see their profiles there on the left. You're looking at the blue curve where you see that LH surge. You see that rise in progesterone compared to the other groups. But of those 12.5%, not a single one had a normal luteal phase length. So even among those who were ovulating, they still had a short luteal phase. And then that other 12.5% there that you see is just the reality of field collection, missing data. We weren't able to put them in one category or the other. But the point here is 42% said they thought they had regular cycles, and we did not observe a single regular cycle in that cohort. So if you want to embark on hormone profiling or starting to try to measure hormones or estimate hormones, there's a lot of different ways to do it in the literature, and they're not all equal. And that's really what the point I want to make today is, thinking about the method that you choose and choosing it carefully is going to dictate the outcome of your conclusion a lot. So the lowest barrier to entry is the LH detection kits, and these are over the counter. You would start measuring them 7 to 8 days after a period starts until you get a positive LH surge. And I want to point out that the risk of misclassification for saying somebody ovulated or didn't is relatively high with this method. You're just seeing if it's about to happen. You're not actually confirming whether it did. If you want to confirm that, you've got to go a little farther. You can do ultrasound or a well-timed serum blood draw, which is harder to do. It's easier said than done, I should say. In the literature, you'll see it recommended about 8 days after that luteinizing hormone surge. What you also see in the literature is a whole range of different thresholds that you could use to say, yes, somebody ovulated or no, they did not. And which threshold you choose is going to change your risk of misclassification. So you have to think about that carefully. If you want to go with a non-threshold method, you can do a blood draw early in the follicular phase to get somebody's baseline level, and then look for a 3-fold increase in that progesterone to see if that rise was appropriate for that individual. That might reduce your risk of misclassification. But your best chance at not misclassifying somebody is frequent hormone profiling, and we're talking every day to twice a week. So serum measures have been done in validation studies and animal studies. Not super practical in real world research environments, but daily urine is, and it tracks really closely with blood measures. And so that's going to be your lowest risk of misclassification, and you can go down to twice a week and still have a reasonably low risk of misclassification. There are quite a few emerging testing options as well. Some of those are in biological specimens like dried blood spots or saliva. think it's worth pointing out that there is limited validation with those methods in athletes, and especially with saliva, there are low hormone levels in saliva compared to blood. There's fertility monitors. These are using urine, and one thing that I forgot to mention in my daily urine profiling is your commercial assays are not well validated against serum, and so you have to correct for hydration either through creatinine or specific gravity, and these fertility monitors don't do that either. So that's something to note there that validate or might change your classification. The final thing I want to mention, and this is a plug for our next two talks, is wearables. Those are great in the sense that they are easy for people to use. Passive data collection, HRV, and skin temperature is what they get used, or what uses. Well, I'm looking at my time here. But anyway, they are poorly validated against actual hormones in athletes at this point in time. Ooh, I want to go back. We had one chance this past year to look at dried blood spots, serum, and saliva in athletes. And I just want to show some of these relationships of these emerging ones. I'm not going to show the saliva because it didn't track well, didn't correlate well, not worth it in this population that we tried. But the dried blood spots were better. So these were international and national level rowers, 26 women at 2 time points. And you'll see the estrogen on the top, progesterone on the bottom, pretty strong correlation there when you look at those scatter plots on the left. But when you look at the bland Altmans, even though the mean bias isn't that much, the limits of agreement are really wide. So right now, not interchangeable, at least without calibration. So we're not there right now. So for now, depending on who you are and what your goal is, I put together this table that I think summarizes some of your options. For the coach, I think cycle tracking, whether that's through apps, calendars, wearables, it can track trends, it can flag risk early. It does serve a purpose and is worthwhile in my opinion. If you want to take it a step further or you think somebody's at risk, you might add that luteinizing hormone detection kit to see if, can we estimate, is ovulation probably happening or not? And that, from a medical standpoint, might help dig a little deeper. But for the research purposes, you're going to want to go further for the most part to confirm that ovulation is actually happening. And of course, your cost and your participant burden is going to go up with each of these things. But if you have a small sample size and you've got the budget to do it and you want to get the biology right, you have to take it a step further and do frequent sampling. I will put a plug in for the wearables again. I think it's good to add these in where we can to start to understand how we can use these in research and how well they work against some of these more valid measures. And our next two talks will cover that. Thanks so much for your time.